So I'm excited to introduce session 11. So we have 4 exciting clinical trial updates. First, we have Dr. Sabi George. He will be talking about a phase 1/2 trial of pazopanib alternating with bevacizumab. Thank you.
Well, good morning, everyone. Thanks to IKCS for selecting our study as an oral presentation here. I'm excited to present the results on behalf of my co-investigators who are from 4 different centers. Particularly want to highlight Dr. Weishenbein, Dr. Clary Appelman, and Parikh. This is the phase 2 results of a trial of pazopanib alternating with bevacizumab in metastatic clear cell RCC. So these are the objectives. As you know, VEGF receptor tyrosine kinase inhibitors are widely used for the treatment of metastatic RCC since 2005. Pazopanib was approved based on its ability to prolong PFS, and the PFS in treatment-naive metastatic RCC patients were 11.1 months. And VEGF ligand upregulation is postulated to be a resistant mechanism against VEGF TKI. And we hypothesized that giving a break from the TKI and introducing bevacizumab during the break could reduce or neutralize the VEGF ligand levels and thus prolonging the PFS. Very simple concept. We tested this in animals and found to be exciting, so we went to phase 1 clinical trial. Here are this is the regimen and mechanism. The regimen is at the bottom. You can see the vertical line marks the end of each cycle. It's a 10-week cycle, 4 weeks of pazopanib, 4 weeks of bevacizumab. Bevacizumab marked by the blue, where they get 2 doses of bevacizumab, day 36, day 50. And after 28 days of pazopanib, there's 1 week off, and 28 days of bevacizumab, 1 week off. And in the upper part, you could see the excursions in the VEGF ligand level marked by the red bars. This is the proposed mechanism. The ligand level should go up with the pazopanib, and it should come down with bevacizumab use, and thus controlling the tumor growth. Now, this multi-center study done at 5 centers, the RP2 dose was pazopanib at 800 milligram daily and bevacizumab at 10 mg per kilogram on day 36 and 50. The primary endpoint was 12-month clinical benefit rate or 12-month PFS rate. The study was designed with a power of 80 and alpha of 0.10 to show a difference with a Simon 2-stage design. Under simplifying assumptions, the PFS rate or CBR rate should go from 45% to 60% with this regimen, translating into PFS from 11.1 to 15.7 months. The demographics on the trial, patients accrued, 51 patients accrued, and male predominant population. We enriched for IMDC favorable risk group because as soon as we started accrual, checkpoint inhibitor combinations were available, and so we wanted to have clinical equipoise. And so the stage 1, the futility stopping rule was not met, so we completed 51 patient accrual, and the final efficacy rule of 28 out of 51 patients was met, and the objective response rate was 54.9%, and clinical benefit rate 98%, and median PFS was 23.3 months, and median overall survival was 64 months after a median follow-up of 35 months. The predominant adverse events included diarrhea, hypertension, fatigue, nausea, and there were not much grade 3-4 events, but hypertension, AST, LT elevation were the common ones. And we still have 5 patients on trial to date. The objective response rate, as shown here, to date there is 1 complete responder. And the PFS and OS shown here in the Kaplan-Meier plot, 3 months and 64 months respectively, PFS and OS. You could see the depth and durability of response from these figures. Left-hand side, the swimmer's plot, and also the spider plot showing how long the patients were on trial, and the waterfall plot showing the depth of response. And the green bar represents the responders. The vast majority of patients had benefit from this regimen. The commonly reported adverse events are shown here, with a very few, exception of ALT and hypertension, very few grade 3 or 4 events. And in summary, this phase 2 trial of pazopanib alternating with bevacizumab met its primary endpoint. This novel regimen was well tolerated and demonstrated promising efficacy and safety in treatment-naive patients, predominantly favorable risk group patients. As you know, none of the IO combinations have been able to show survival advantage in favorable risk group patients. So this may be relevant there, and also may be relevant for patients who cannot get checkpoint inhibitors. And the PFS and OS from this novel trial regimen are promising, and no new safety concerns emerged. We had a lot of patients with the proteinuria, a few patients with proteinuria, but none of them amounted to requiring, discontinuation of dose. And we did not see any microangiopathic hemolytic anemia as seen by some other trials which combined the two drugs in various trials. And this novel regimen could be a viable option for MRCC patients with IMDC favorable risk group. So what does this mean on Monday? Practice change, I don't know if that would happen, but we're hoping that this will be relevant in this small space. It could be a viable option for metastatic RCC patients with favorable risk group and patients who cannot receive immune checkpoint inhibitors. And last but not least, I want to thank all our patients, families, co-investigators, sites, and coordinators. This work was supported by Russell Park Comprehensive Cancer Center and NCI grant and Novartis. And statistical support was provided by Drs. Hudson and Groman. And we have tons of biomarker samples. I'm hoping to report on that in the subsequent meetings. Thank you.
Thank you, Dr. George. Next, my pleasure to introduce Dr. Brian Schock from UCLA to discuss his poster about canine prospective comparison of contrast-enhanced CT scan versus zirconium PET CT scan in recurrent clear cell kidney cancer.
Okay, thanks, Youssef. So this is just a trials in progress, something that we have launched recently with the assistance of Telix and on behalf of my team at UCLA. Just going to give you an update on where we're moving forward with this agent in the post-op staging area. Of course, you need a cool lingo to have a cool trial, so it's K9 or CA9. So after resection of high-risk clear cell kidney cancer, we know conventional imaging is used. It helps us restage to see if there's any disease left behind. We know it's not reliable in calling something cancer that's small. We know that we're really horrible at diagnosing bone lesions on bone scan, as these are osteolytic. And we know that sometimes postoperatively in the renal fossa or reactive nodes are just related to the surgery. And PET tracers with FDG, PSMA, dotatate, they improve staging for some of our cancers that our colleagues treat. So CA9 is expressed in the majority of clear cell kidney cancers due to VHL loss, due to HIF dysregulation, and obviously CA9 has been exploited as a diagnostic target of immuno-PET CT, and it may augment some of the limitations on conventional imaging to diagnose clear cell kidney cancer. And in the kidney, it makes sense because there is uptake of FDG, there's uptake of PSMA, so it's not really able to be used for primary kidney imaging. The ZIRCON trial did show that it showed excellent positive predictive value, 93% in diagnosing primary clear cell kidney cancer. But can we expand that? So we do know that in our field, adjuvant immunotherapy with pembrolizumab is supported by level 1 data. We were all thrilled to see a small, modest overall improvement at 4 years in the Keynote 564 trial. But we do know that many of our patients are overtreated. 60% of our high-risk patients on a lot of the adjuvant trials do not recur. We do know that many of our patients are undertreated when they really have M1 disease. 10 to 14% of patients, if they are imaged and looked at, have residual disease on their first post-op scan and are thus ineligible for a lot of these trials. Some patients in the community actually don't get re-imaged because they're not part of a trial. 1/3 of our recurrences occur within the first 6 months, and in hindsight, a lot of those lesions were present at baseline. We do know a lot of our urology colleagues, we sometimes do chest x-rays. We don't do chest CT before surgery. So I would say that sometimes we do miss patients. And then we do know that IO monotherapy, at least with M1 disease, it looks inferior, hasn't been compared head-to-head, but clearly the response rate for monotherapy pembro looks to be lower than pembroaxi or len-pem, et cetera. So those patients may be undertreated if they really have disease. What's your experience with whole-body PET-CT? The largest experience is from the Netherlands. A group from Radboud led a couple sites, 42 patients with M1 disease prior to systemic therapy, and they looked at the diagnostic rate for PET-CT with FDG, with the TLX250 or zirconium, girentuximab compound, or CT. And they found the most lesions, 91% of 449 lesions, was with the CA9 PET-CT, and the SUVs are very high, looking at, these are in the range median of between 10 to 60, clearly very different than, if you look at FDG or PSMA, these are very PET-avid, very low background, and it is very exciting that you can detect disease, more lesions detected. We've imaged over 55 patients now on the expanded access program, the Zircon trial, and on our staging trial. So we do see that we can find lesions, rib lesions, soft tissue lesions, mediastinal lesions, nodes, and they are clearly present with high SUV. So the question is, does the TLX250 PET-CT, is it superior to conventional contrast-enhanced CT for post-operative staging for high-risk clear cell kidney cancer, giving our patients the appropriate care that they need? So we have key inclusion criteria. Obviously, clear cell kidney cancer, they had to be treated. This is their first imaging study after surgery. They have to have high risk. This is kind of between our emotion criteria and our keynote criteria. I didn't think that 1 year after resection to NED really was that important versus 2 years. But these are really the high risk patients after treatment. They can't have had prior imaging, they can't have to have suspected residual disease, and they have to be able to get contrast agents, and they can't have had systemic therapy for kidney cancer before. So we have a special CT PET scanner, which actually is a very thin slice CT. We have the ability to give patients contrast at the time of their PET scan, and we've done trials where we've actually split images where the nuclear medicine docs read one film or the abdominal radiologists read another film. So patients get their imaging study with CT with contrast. It's going to be from chest, abdomen, pelvis, but they have a whole body scan with the girentuximab zirconium agent. They get a clinical report with a disclaimer, it's for research. And then on a central review later, it's split between 3 central radiologists and 3 central nuclear medicine docs. We follow them for 2 years and try to look for things like lesion validation. Patients are getting questionnaires, they're getting ctDNA, we're collecting the tumor. We want to see, does this imaging lead to additional biopsies or surgery, additional imaging for characterization? Does it lead to patients having change in their adjuvant therapy plan? Are we now escalating their therapy to maybe dual IO or dual IO-TKI? Or are patients saying, hey, I don't have any disease, now I kind of want to watch the tumor and just get surveillance? We are looking at lesion detection rate as the primary endpoint per patient, looking at PET scan alone versus CT with contrast alone, and looking at clearly the safety and the post-op setting, change in management, the positive predictive value. If you see a lesion, it's positive, you want to confirm it with standard of truth. The histopath if it's biopsied, if there's growth on surveillance, if there's shrinkage or growth with treatment, or if you have an MRI or some other scan that says it's unequivocally a cancer. And then we look at DFS. I would hypothesize that the DFS for patients might be different if they have clearly positive or negative disease. We're going to do some correlation with the H-score from the primary tumor with the SUV rate. We're going to look at, the SUV cutoffs, correlate ctDNA with the findings, and also look at some of the transcriptomic classifiers predicting disease from the primary. We do expect some patients are going to convert to non-metastatic disease to metastatic disease with the addition of the PET scan. We don't think that patients are going to convert, from the PET scan to the other way to the contrast enhanced. So we anticipate a cohort of about 91 patients to show really a 10% additional number of patients detected. We do think that this is super exciting to our field. We're super thrilled to offer this to our patients with localized disease. We want to start moving it later for post-op staging, obviously for metastatic disease as well, and there are plans for that as well. Biomarkers of post-treatment recurrence, they do hold promise to really identify who needs aggressive treatment, and this might help us improve outcomes. We think that the canine trial will help us really improve the standard of care. We're hoping to help patients get the appropriate treatment, whether it's adjuvant pembro, whether it's surveillance, or whether maybe they need more aggressive treatment. Thank you.
Our third presentation is from Dr. Pooja Gatalia. She'll be talking about a pooled analysis of 4 clinical trials of belzutifan.
Thank you to the organizing committee for letting us present the pooled analysis of 4 clinical trials looking at characterization of safety profile of belzutifan in patients with metastatic RCC. The learning objectives are, what is the safety profile of belzutifan, a first-in-class HIF-2 alpha inhibitor, and how are common AEs for belzutifan managed? So belzutifan, dosed at 120 milligram daily, is currently approved for patients with VHL disease-associated RCC, CNS hemangioblastomas, or PNETs, not requiring immediate surgery, based on approval in 2021. And in December 2023, it was approved for patients with advanced RCC previously treated with checkpoint inhibitor and VEGF TKIs. Because belzutifan has a unique mechanism of action and a distinct AE profile, which includes anemia and hypoxia, we present results here of a post-hoc pooled analysis of belzutifan safety in patients with RCC from 4 clinical trials. So here are the 4 trials that were included. The first is the LIGHTSPARK-001, which was a phase 1 dose escalation study with multiple tumor types, including RCC. Then we have LIGHTSPARK-004, which was an open-label phase 2 study which included patients with VHL-associated disease. And LIGHTSPARK-005 was the largest of these 4. It was a randomized phase 3 trial which randomized patients to belzutifan versus everolimus and included heavily pretreated patients with metastatic RCC. And LIGHTSPARK-013 was a phase 2 randomized 2-dose study, which also included patients with advanced RCC previously treated with immune checkpoint inhibitors. Among these different studies, the LIGHTSPARK-005 contributed 67% of the patients, and we have a total pooled population of 576. So the baseline characteristics of this population included a median age of 61, 76% were men, about 50% had ECOG performance 1 to 2, and the study population represented a huge part of the world with about 40% of patients from West Europe, 40% from North America, and 22% from the rest of the world. So almost every patient had at least one all-grade, all-cause AE, but all-cause grade 3 to 5 AEs were seen in 61.6% of patients, and treatment-related grade 3 to 5 AEs were seen in about 40% of patients. These AEs caused dose modifications in about half of the patients, but number of patients who had to discontinue the treatment due to the AEs was relatively small, just 6%. Treatment-related AEs led to death in only 1 patient due to multiple organ dysfunction syndrome. The most common AEs were anemia, fatigue, nausea, and of note, hypoxia. Anemia was seen in about 84% of patients, And in about 28.8% of patients, grade 3 to 4 anemia was noted. Grade 3 or 4 hypoxia was seen in 12.2% of patients. So grade 3 or more anemia correlates with a hemoglobin less than 8 or requiring transfusions, and grade 3 hypoxia implies an oxygen saturation of 88% or less at rest. The time to onset of any of these common any grade AEs was usually around 30 days, so about within the first month. Now, among the patients who had anemia, which was almost 84% of patients and 28% of patients with grade 3 anemia, the median time to onset was about 29 days, and the median time to resolution was 70 days. The way these anemia was managed included the use of erythropoiesis-stimulating agent in about 23% of patients, blood transfusions only in 17% of patients, and the combination of ESA and blood transfusions in 13% of patients. About 30% of patients received other treatments, which include vitamins or iron supplements. The median number of ESA injections per patient was 5, and the number of blood transfusions a patient received, median number was 2. Among the patients who had any cause anemia, so 94 patients out of the 576 had any cause hypoxia, and patients with grade 3 hypoxia were about 12% of patients. About 70% of patients required oxygen to cope with the anemia that they had. The median time to onset, again, of this hypoxia was about 30 days. And so to conclude, belzutifan had generally a manageable safety profile, and a few patients discontinued treatment due to AEs across a pooled analysis of 576 patients across 4 clinical trials. The AEs had a relatively early onset, with median time to onset within the first 3 months of treatment. Only 6% of patients discontinued treatment because of AEs. As expected, anemia and hypoxia were among the most frequent AEs, and they were generally managed with dose modifications, and in case of anemia, treated with ESAs or blood transfusions, and in case of hypoxia, supplemental oxygen was used. To date, this is the largest pooled safety data set for a HIF-2 alpha inhibitor. Belzutifan has a unique mechanism of action from other approved treatments and is the only treatment approved in patients with VHL disease tumors. And so these results provide an in-depth characterization of the safety profile. And the take-home message is that belzutifan has a safety profile that is distinct from other drugs used for treatment of RCC, with anemia and hypoxia being the most common toxicity that can be managed. Thank you.
Thank you, Dr. Gatalia. Next, my pleasure to introduce Dr. Pavlos Saul from MD Anderson to discuss phase 1 study of sitravatinib combined with ipilimumab and nivolumab in patients with advanced clear cell RCC. Pavlos.
Thank you. On behalf of my co-authors, I'm pleased to present the results of this phase 1 study. The learning objectives is to learn the challenges of developing triplet immunotherapies in kidney cancer and learn the value of incorporating single-cell RNA-seq correlatives in trial designs. And as a background, sitravatinib is a TKI that inhibits VEGF, MET, and TAM receptors. You can think of it like cabozantinib, but potentially more immunogenic, then can augment the immune response to nivolumab. We have shown that it can do that in clear cell RCC, both in the metastatic and the neoadjuvant setting. So we wanted to see what would happen if we added sitravatinib now to nivo-ipi. And so we did a phase 1 trial to determine the best dose in 22 previously untreated, treatment-naive patients with advanced clear cell renal cell carcinoma. The primary endpoint was to establish a safe dose, and secondary endpoints included objective response, DCR, PFS, and 1-year OS probability. And exploratory endpoints included correlatives, gene expression signatures, and immune cell populations. This is the trial design. We gave standard dose of nivo-ipi, 4 doses followed by nivolumab maintenance, and we added the TKI sitravatinib. At the data cutoff of August 25, 2023, the median follow-up was almost 16 months, and 7 out of 22 patients continued to receive treatment on trial. And importantly, we collected tumor biopsy samples at baseline prior to the second infusion, so about 3 weeks after the first infusion of nivo-ipi and starting sitravatinib. On the same day, patients would start sitravatinib daily, and at disease progression. These are the demographics. Most of patients had intermediate risk IMDC score. We had about 27% had sarcomatoid and rhabdoid histology, mainly rhabdoid, nothing pure sarcomatoid, and no huge amount of sarcomatoid proportion. And this is what happened to the trial at broadly. We started with sitravatinib low levels, 35 milligrams. That's, for context, it's about similar to giving cabozantinib 20 milligrams. And we noticed that 6 out of 7 patients had IRAEs. Now, those IRAEs did not exactly fulfill our DLT criteria, even though, we're very careful about that, but they were severe enough. They included myocarditis, colitis, myasthenia gravis, pneumonitis, like severe stuff that told us, hey, this is not an easy triplet to combine with the standard backbone of nivo-ipi. So given the fact that there were data at the time that if you reduce the dose, we believe that this was mainly due to the ipilimumab because we have already successfully combined sitravatinib with nivolumab. There were data that if we reduce the dose of ipilimumab, we might reduce toxicity and maintain efficacy. Keep in mind that most of the IRAEs happened after the first or second dose of nivo-ipi, so the idea of prolonging the interval was not appealing. So we did that. We reduced ipi to 0.7, and we were able to dose escalate to the final planned dose of 100 milligrams. That was cohort 4. That's, let's say, the equivalent of cabo, 60 milligrams. And this is what happened again in cohort 1 with the standard backbone of nivo-ipi. Very nice responses. You can see a lot of objective responses, but also a lot of toxicities. And you can see here the waterfall plot and the swimmer plot by cohort dose. So overall, objective response rate 45%, a median PFS of 14 months. And in cohort 4 in particular, we may have seen a decline in efficacy versus the promising efficacy of cohort 1. Objective response rates around 30% and disease control rate of about 89%. Importantly, we had the longitudinal samples, very, very useful for understanding what happened to these patients. We got baseline biopsies from 12 patients, which we divided into the ones that responded. They're encoded as pre-ER in the figures, and the ones that did not have objective response, pre-NR. And then post is the after the first infusion, and we got it from 4 patients, and then end of treatment from 3 patients. All of them had baseline samples. We got epithelial cells. We were able to separate them using our standard informatic techniques into tumor cells, and we were able to identify a cluster, which we called C8, that you can see starts to get enriched as soon as you start giving the therapy. And interestingly enough, this is the cluster that was associated with the worst treatment responses, including when you put that cluster in the baseline, like the baseline samples that had enrichment for this cluster, they were the least likely to respond. And when we analyzed this cluster, it had an EMT-like signature, as you can see here. We took the signature from that cluster, and then we threw it in the bulk RNA-seq from the TCGA, and you can see how very nicely it separates as an external validation the disease-specific survival, both in univariable analysis or multivariable if you add disease states, if you add presence or absence of neoadjuvant therapy, and it also pan out with overall survival. All of them highly statistically significant as a signature. Then when it comes to the microenvironment, you can see here, as expected, that once you start the TKI, for example, you start getting immediately less endothelial cells. Nice validation that, what were the signals we're getting actually makes sense. And you can see here that if at baseline patients had a more fibrotic immune microenvironment, they were less likely to respond, interestingly. Then we took a signature published by our informatics group in Nature Medicine last year in a pan-cancer setting. So we took that signature and we noticed that, indeed, validating what they had found in the pan-cancer setting, the end of treatment, the resistant now tumors had more of these CD4 Treg cells, and more importantly, we would see at the CD8 level more of what they call last year this stress response, these CD8 T cells expressing heat shock proteins and what we call a stress signature. There was an enrichment as well, both in the non-responders at baseline and at end of treatment for the M2 macrophage signature. And so in conclusion, sitravatinib could not be combined with ipilimumab 1 mg per kg plus nivolumab 3 mg per kg due to its immunogenicity, we believe, causing the immune-related adverse events. The recommended phase 2 dose would be sitravatinib 100 milligrams, which is the highest monotherapy dose as well, achieved in phase 1 setting, plus EP 0.7 and plus nivo 3 mg per kg. But this may have come at the cost of reduced objective responses in cohort 4 compared with what was initially observed in cohort 1 using the standard 1 mg per kg ipilimumab backbone. Treatment resistance within the tumor microenvironment was characterized by a shift from cytotoxic to exhausted T cell states and an increase in M2-like myeloid cells. We identified a tumor cell-specific transcriptomic signature linked to treatment resistance and poor outcomes. And the observed changes in gene expression and cellular states highlight potential biomarkers for resistance and may guide strategies to enhance immunotherapy effectiveness. This may be the face of the enemy now. This is what the tumor cells may turn into after you give the strongest therapies approved for clear cell kidney cancer. Nivo-Ipi, anti-VEGF broad-spectrum TKI, that C8 cluster may teach us what we need to target now to bring new MOAs for clear cell renal cell carcinoma. This is exactly why, upon publication in the next few weeks, we will make the data available in GEO, and that's the accession number here, and we will allow interactive visualization and allow people to play with this data, refute them, try to use them any way possible in our single-cell research portal, which is here. The take-home messages, again, sitravatinib could not be safely combined with IP 1 mg per kg due to IRAEs. We need a dose reduce, but there is value in correlatives that can help us push the field forward. Thank you very much for your kind attention.
We have 7 minutes for questions.
I have one question for Dr. Gatalia while everybody gets to the microphone. So based on your data, what do you practically recommend your patients starting on belzutifan about monitoring for hypoxia? So I noticed shortness of breath or dyspnea wasn't high up in adverse events, and anecdotally it seems like it may be asymptomatic.
In clinical practice, we have been asking patients to invest in a pulse oximeter or use it if they have it. A lot of patients have it nowadays after COVID. And if they notice changes in their oxygen saturation, then to notify us immediately.
Dan?
Great talks, really interesting. Just one quick question for Brian. With the imaging trial, did you guys think about using it prior to surgery to make sure you're not operating on patients with already metastatic disease, sort of like a la PSMA PET CTs?
Yeah, so again, that's obviously something that is planned. We have a protocol with large tumors that is in process. But again, some of the large tumors might not be clear cells, so you might miss a large portion of them. But that's obviously where the field needs to move to understand nodes or other types of areas, and maybe patients wouldn't always benefit from upfront surgery.
Jim?
I had the same question.
Okay. Monty?
for Pooja. Great presentation, and that was fantastic. I struggle with something in clinical practice, and that's when to jump in with ESAs. And I was just looking at your data there, and it seems like the median time of onset of use of ESAs is around 85 days or so. So does that mean people are, kind of dose reducing and then jumping in with ESAs at like a dose of 40, or what's kind of the standard practice in that setting?
Yeah, so typically before the use of ESAs, we do try to dose reduce. Dose reduction is usually used as the first strategy. And the use of ESAs is typically triggered when the hemoglobin is less than 8. That's typically what is considered. And also it's not scheduled, so it can be used on an as-needed basis.
Looking forward.
Nizar.
Thank you. A great session. Just I have two questions. First to Pooja and then to Pavlos. Pooja, many insurance carriers are pushing back on approving ESAs for these patients. And I think they're requiring, anemia workup. And first of all, we do not know if, patients will benefit from ESA. And so do you have serum erythropoietin levels on these patients from these 4 trials? And if not, I really think we need to do that. First to convince, insurance carriers if these if these serum erythropoietin levels are low, then they will readily approve it. But maybe we won't find a correlation between the anemia and the erythropoietin level, and maybe we do not know if really giving these injections really help patients. Although I do believe that some patients are benefited. We see that in some patients where we give ESA, the hemoglobin improves. But I think this is an important, really, moving forward, an important thing to look at in terms of it. So Pavlos, great presentation, great trial, of course. And this is, just giving a little propaganda here. The first trial of a triplet showing correlative studies with single cells, sequencing and all the, immunoprofiling, et cetera. So great work. If you had an opportunity to continue developing this triplet therapy, what would you do? Let's say there was no business decision to stop development of Citra and you were able to take it to the next trial. What will be that trial to incorporate a TKI with nivo-ipi, which we really know that nivo-ipi is the backbone of first-line therapy for clear cell RCC. Obviously you saw that if you're going to be able to give Citra at the fullest dose of 100 milligram daily, you had to drop the dose of ipi. But would that compromise the benefit of nivo-ipi? Because we know it's 3 and 1 is the standard dose schedule. Would you, in retrospect, have given ipi 1 mg per kilo, but not every 3 weeks, but more like every 6 weeks? So thank you for a great session, and thank you for answering these 2 questions.
So they have been collecting EPO levels, but those results are not reported. I'll definitely urge the team to look into it.
Your question for people is, it was spontaneous. You hadn't asked me this question before. So with regards to nivo-ipi 1 mg per kg, because the IRAEs, many of them happen after the first dose, or they started shimmering after the first dose and they definitely manifest after the second dose. That's why we didn't think that doing 1 mg per kg over a longer duration would be feasible. That's why we decided dose reduce, and it was something we wanted to explore, see what generate some data on this. If I was to do a phase 3 trial on this, that was why the idea was to maximize the TKI dose, because I suspect that if the control was nivo-ipi, with nivo-ipi, ipi 1 mg per kg, because of the TKI effect, it would probably win when it comes to PFS. OS, it's hard to say, especially with subsequent therapies available, but that's how I would design it. The control should be nivo-ipi.
Between Nizar and Pavlos, we lost all the time. So one last question for Tian, maybe. Sorry about that.
Okay.
Pavlos, great work. I think we really need to drill down on mechanisms of immunotherapy resistance, and I'm really glad that you're looking at all this immune cell subsets. two questions. One is, do you see any loss of tumor antigen presentation, MHC class 1, for example? And then the second question is, how scale-upable do you think these single-cell transcriptomics will be in larger data sets?
Great question. So in one of the sub-figures, we actually did show that in the C8 cluster, there is downregulation of B2M, which is a component of the MHC class 1, exactly as you predicted. So that is evidence for that. With regards to doing single cell, that's why we took this signature, we put it in the TCGA, the EMT signature, and it was validated. I think that, there are pros and cons to using single cell. It can be difficult to scale it up in every patient. Our lab does everything without a core from beginning to the end, from the biopsy to data analysis. We do it, but I know that's difficult. There are thankfully bulk RNA-seq companies these days that are able to deconvolute bulk RNA-seq that generates data almost as good as our single-cell RNA-seq. And I think that is much more scalable and can be done at a big level for bigger trials.
All right, thank you for the audience and the panelists for a great session. And we invite you to session 12, I think Manoj and Monty. Thank you very much.